together. So today I'm just going to be showing you cases, and I'll be asking you to comment on some of these cases that I think are, some of them are good teaching cases, but in a different way. These are often not typical cases, but somewhat unusual, and yet still things that you may see occasionally in your practice. So I'm going to start with just reviewing in somewhat more depth, because I touched on this during the course, but it's an area that I think it's critical for you to understand, because these benign vascular malformations are extremely common, and the more you know about them, the easier they are for you to recognize, and the less chance you'll have of thinking that there's something that may be harmful to your patients. So benign vascular malformations are really quite common, and I'm sure you see them all in your practice in one fashion or another. And again, mistaking them for disease can lead at its simplest level to unnecessary imaging, but at worst can lead to unnecessary procedures. So we'll start with the capillary telangiectasia. Now, these are usually solitary and asymptomatic. They're most often seen in the pons, and histologically, they represent dilated capillaries. There is intervening brain within the capillary telangiectasia. So on MR, what we see is stippled enhancement with little or no signal abnormality on the T2-weighted imaging. One thing you should be aware of is that traditionally we would say that vascular capillary telangiectasias were not visible on gradient echo imaging, because the thought was that these do not contain hemosiderin like the cavernoma. But the susceptibility weighted imaging that is now available on many scanners has a higher degree of sensitivity and is actually responding to the deoxyhemoglobin within the capillary telangiectasia. So if you see them on susceptibility weighted imaging and you think it's a capillary telangiectasia, do not read them as cavernomas on the basis of that visibility on susceptibility weighted imaging. Now, this is a nice, obviously from an autopsy case, a cut section through the brainstem showing you the capillary telangiectasia here. And you see the way the normal brain structure courses through the lesion. So unlike the cavernoma, which contains no brain tissue, the capillary telangiectasia is woven into the normal brain. And again, these do not provide a source of hemorrhage. These are not symptomatic. And the reason I want to discuss them today is because they're frequently mistaken for something else like metastatic disease. And I can't tell you how many times, surgeons have come to me with scans from the outside where these have been read as something more worrisome. This is what the histology looks within a capillary telangiectasia. These are the dilated vascular structures that we're seeing, and of course, interwoven through the normal brain tissue. This is a typical appearance of a capillary telangiectasia, and it lies within the brainstem. And you can see why, if you get a scan like this in a patient where the clinical question is rule out metastatic disease, that there may be a tendency to focus on this as a potential metastatic lesion. Here's a different case. Now, they're not, I want to show this case because capillary telangiectasias are not always within the pons or brainstem, and they can be seen elsewhere, usually in the cortex or basal ganglia. Now, this is probably a combination of a developmental venous anomaly and a capillary telangiectasia. They often are seen in conjunction. The thing you will notice here is that on the FLAIR scan, there's no abnormality. On the T2 weighted scan, there's no abnormality. So again, typical findings for a capillary telangiectasia is they're quite visible on the enhanced scan, but difficult to find on the other routine imaging. They're not always single. This patient actually has two capillary telangiectasias. You see here on the post-contrast T1 weighted MR scan, you don't see anything on the FLAIR scan. Now, if you were to have a high degree of suspicion for metastatic disease, I do think it's reasonable in some cases. For example, small cell lung cancer is one which is frequently metastatic to the brain. So if you have a reasonably high degree of suspicion, and particularly if the patient is symptomatic, you need to repeat the scan in, say, a month to make sure these are not enlarging. So the fact that they're not visible on the FLAIR scan does not establish the diagnosis of a capillary telangiectasia, largely because not all metastatic lesions will be visible on FLAIR imaging. As you know, the vasogenic edema that we usually associate with metastatic disease is often absent when you're dealing with lesions where there is dense fiber packing. For example, you can see that in the brainstem. You also see that in the cortex because of the tight neuronal packing. It seems as though it limits the degree of extension of vasogenic edema. Here's another capillary telangiectasia, this one with kind of an irregular border, well seen here in the pons in this patient on the post-contrast T1 scan. This one had a little bit of signal on the T2 weighted scan. Shouldn't be enough for you to suggest a different diagnosis. And this is what I mean about them being visible on the SWI scan, is that the fact that you see it on the SWI scan does not automatically make the diagnosis of a cavernoma. So you can expect to see this on occasion with capillary telangiectasias. I've also seen this with patients where they've been followed for a long period of time, where all of a sudden, the old scans don't have SWI imaging available. Now you do, and you see it on the SWI, and people will misinterpret that to mean that they hemorrhaged in the interval. So again, this is an expected finding with capillary telangiectasia. Here's yet another capillary telangiectasia. Again, in the pons, this one's right in the midline. Again, very difficult to see here on the FLAIR scan. So typical location, typical appearance. This is another variation. Here you see this patient has a prominent enhancing vein, a number of branching vessels. This appearance is typical for a developmental venous anomaly. In the drainage bed of the developmental venous anomaly, you see this patch of enhancement. So this is likely a combination lesion of capillary telangiectasia and developmental venous anomaly. Here you see it, same patient in the coronal scan. Branches, this is the caput medusa of the developmental venous anomaly. Here's the blush of the capillary telangiectasia. Does this patient need any, should we attach any concern to either of these lesions? The answer is no. Capillary telangiectasias do not hemorrhage. Developmental venous anomalies are a normal variation of venous anatomy and should not require any real follow-up. Now we'll move to what I think is probably the most common abnormality I see in my own practice is the venous angioma or developmental venous angioma. These are almost always clinically silent. The reason I say almost always is because I've shown you cases of thrombosed developmental venous anomalies. So, but I would say in 99% of cases, the venous angioma is not clinically evident. Histologically, these are tufts of enlarged medullary veins. They drain to a central vein that is usually oriented perpendicular to the cortex or the ventricular margin. And since they drain normal brain, they should be considered normal variants, thus the term developmental venous anomaly. Now, it's important for you to recognize these and describe them in your reports when they're near a lesion that might require surgery, such as a tumor or a cavernoma. Because when a developmental venous anomaly is occluded at the time of surgery or resected, the patient may experience venous hypertension or a venous infarct. On digital subtraction angiogram, the findings are described like a spoke wheel or Medusa head. You may remember Medusa from mythology with the head of snakes. And here they drain into a single large channel. On DSA, it's essential that the draining vein does not appear before other veins. That is, the vein enhances in the same timing as the normal veins. If the vein appears early, so-called early vein, then you're dealing with some sort of vascular shunt. For example, this is an angiogram of a patient with a particularly large developmental venous anomaly. These are all the collecting veins of the capita medusa. Notice that you don't see the draining vein quite yet. On this frame, now you see the large draining vein perpendicular to the cortex. Here, it looks like it's draining to the superior sagittal sinus. Also notice at the same frame that you see the draining vein, now you see the thalamostriate vein, the internal cerebral vein, and so on. So the fact that I see other veins, here's some cortical veins as well. So the developmental venous anomaly vein should drain with the same timing as the normal venous anatomy. That is the critical feature to establish the diagnosis in cases where there's some question. I'm going to show you this angiogram from a different patient just to illustrate the difference in timing. Here we are in a mid-arterial injection from an internal carotid artery. Here you see the middle cerebral branches and so on. Now we see here, this is not an artery, this is a vein. And so the early appearance of the vein, and here this odd collection of vasculature, and this may be an intranidal aneurysm. This is an arteriovenous malformation with the appearance of an early vein. So again, that's the distinction between a DVA. For example, if you think this is like a caput medusa, the presence of the vein in an early arterial phase would argue this is an arteriovenous malformation. Sometimes all you see is the draining vein. This is a CT scan, of course, with contrast. And here you see the large draining vein coursing perpendicular to the cortex. We don't see on this particular CT the branching caput medusa. Here's another one where really all we see is the large draining vein. So don't mistake this for some other process or an arteriovenous malformation with a draining vein. The other thing you'll notice is that the draining vein on developmental venous anomalies always enhance. So we don't have enough flow velocity in the vein to give you the signal loss that we expect with an arteriovenous malformation. Here's yet another case of a developmental venous anomaly. Here you see the draining vein and the branching caput medusa in the cerebellum. Now, this is a patient, here you see a developmental venous anomaly here on the CT scan. Here it is on the angiogram. Again, large draining vein, caput medusa. Notice the timing. This appears around the same time as the other. We start to see some venous filling here in the sigmoid sinus on the other side. Now, this is an example of a combination lesion. I showed you a developmental venous anomaly with a capillary telangiectasia. This is a developmental venous anomaly. Here's the branching caput medusa. Here's the draining vein. But on the susceptibility weighted scan, you see this large area of signal dropout. This is a cavernoma in the bed of a developmental venous anomaly. These commonly go together if you look for them. And I think the surgeon, in a case like this, if they were going to resect this cavernoma, they need to know about the nearby developmental venous anomaly so that they don't mistakenly resect that. So again, this is a combination lesion. These are not a rare entity. And if you look for them, particularly in the brainstem cavernomas, you'll see a developmental venous anomaly nearby. Here's a few questions I want you to consider. True or false? Cavernous angiomas never have mass effect. Cavernomas are congenital and don't appear in adults. Cavernomas are always intraaxial. So think about that to yourself. How would you answer these as true or false, each one? And I'm going to tell you that these are all false. Some cavernomas can grow quite large and have considerable mass effect. These are not all congenital, and you will see cases where a cavernoma appears for no discernible reason on a scan where you have multiple previous exams where it was not present. And cavernomas are not always intraaxial. You can see extraaxial cavernomas frequently in the cavernous sinus region. One way you can distinguish a cavernoma from a meningioma in the cavernous sinus is that the cavernomas will have T2 prolongation, that is, they'll look bright on the T2 weighted scan, while meningiomas are almost always dark in the cavernous sinus region. In terms of natural history, this is a problematic area because in terms of recommendations for surgery, you need to know the natural history, but it's actually not particularly certain, and you'll see a range of values in terms of risk of hemorrhage, almost a 10-fold range from 0.5% to 5%. They are dynamic. You'll see them grow. You'll see them regress. They can cause headaches that come and go. But again, the histology of these is dilated thrombosed vascular channels with no intervening brain. This is a cavernoma seen here on a different autopsy specimen. And if you see the sort of perforated appearance of the brain within here, and it helps that we look at this and understand this, because this is how a surgeon can find if the lesion comes to the surface of the brain. Once a surgeon enters the cavernoma, they can resect the core of the cavernoma without any deficits, because there's no brain inside there. Now, the hemosiderin stained rim that you actually see here on this cut section, this is one area that is thought to be problematic in resections of cavernomas in patients with seizures, because in a typical cavernoma resection, they take the core, but in some cases of cavernomas that cause seizures, the surgeons may have to resect the rim where there is normal brain tissue and increases the risk of a deficit. This is the histology of a typical cavernoma. Again, you see these dilated vascular channels and no intervening brain here on this section. Now, this is a large cavernoma, and you see the mass effect on the fourth ventricle. So again, don't get it in your mind that that these lesions are, sort of small and don't displace any normal brain tissue. They can become quite large, and this appearance, these multiple sort of areas of T2 prolongation with a low signal intensity here, completely dark rim. These are typical features with cavernomas. Don't let the mass effect lead you to a different diagnosis. Here's another cavernoma here adjacent to the ventricle. These can be purely intraventricle and may lead to superficial siderosis. So you can see that together as well. This is sometimes described as a popcorn appearance, these multiple areas, small areas of T1 shortening. And so these are probably areas of pockets of subacute blood that gives this appearance. But again, all cavernomas should have a dark hemosiderin rim visible on T2 weighted imaging. Cavernomas can also occur in the cord, right? So even this looks like a cavernoma that you might see in the brain with this kind of intermixed signal and some signal dropout on the T2 weighted scan. So just because it's in the spinal cord does not mean it's not a cavernoma. And here you see on the axial scan, the low signal intensity from the hemosiderin. In terms of treatment, this is an area that varies with location and surgeon skill. Resection should be considered when they're associated with intractable epilepsy, and sometimes it should be considered after symptomatic bleeding, but not in all cases. In terms of location, we think of the brainstem and midbrain as being a surgical kind of no man's land because of the vital structures in those locations. But again, if the cavernoma is associated with hemorrhage, the surgeons may enter the cavernoma if they come to the surface of the brain through a selected pathway and resect the sort of the core of the cavernoma. Because the outcome of brainstem cavernomas is actually worse than that of the hemispheric cavernomas. So how do I know when I'm looking at a DVA and not an arteriovenous malformation? This is not a trivial question because you're going to see cases where it's sort of an in-between look to it. So be aware that there's no non-invasive imaging that can establish the arteriovenous shunting that I showed you was a hallmark of the developmental, the DVA. So if you want to firmly establish the diagnosis, you need to do DSA. But in many cases, you can establish the diagnosis with MRA. You want to look for bright vascular channels within the DVA because 3D time of flight tends to recognize high velocity flow. If you see flow voids on T2 weighted imaging, you should be suspicious that you're looking at an AVM. If the entire lesion does not enhance after administration of contrast, you should again be suspicious you're looking at an AVM. Like I'll show you this case, here we see this area of low signal intensity in the inner, in the Sylvian fissure here. Here it is on the 3D time of flight MRA. And again, if you see the lesion is bright on the MRA, that is an indication that you're looking at an arteriovenous malformation in a sense that it looks just like the middle cerebral branches here in the Sylvian fissure and the anterior cerebral arteries here in the interhemispheric fissure. So this would establish the diagnosis of an AVM rather than a DVA in this case. Here's another patient. We see this area here on the post-contrast imaging. Occasionally, cavernomas will enhance. And so here we see this area of some little bit of enhancement. Now, is this a DVA or an arteriovenous malformation? The finding that you should establish here, and this is an excellent demonstration of this phenomenon, in a normal DVA, the draining vein should enhance on MR imaging. But you'll notice this internal cerebral vein is dark, while the normal contralateral internal cerebral vein enhances homogeneously. This is an indication of high velocity flow in this internal cerebral vein, which established the diagnosis. This is an AVM, not a DVA. Now, I mentioned these mixed vascular abnormalities. And these are the most commonly encountered mix is the DVA with the cavernoma that I showed you. But you need to be looking for these, and oftentimes special sequences are needed to detect both lesions. The best way, of course, to detect the hemosiderin is with SWI imaging. The best way to detect the DVA is to use a very thin section post-contrast T1 3D technique because you need to look at thin sections. Here's just another case of a developmental venous anomaly with a cavernoma in this 62-year-old patient. Here, in this case, you can see the hemosiderin staining. Here's the dark hemosiderin ring, typical for a cavernoma on the right. But if you look carefully at the post-contrast imaging, you can see in the ipsilateral hemisphere, there's also a developmental venous anomaly. So look for these together. In this case, you can see there's a small midbrain cavernoma. There's a little area of signal dropout. And so here you see a little bit of signal on the T2 weighted scan. And if you look carefully in that same patient, you can see there's also a developmental venous anomaly. So very common with brainstem developmental venous anomalies will accompany cavernomas. Here's another cavernoma. Again, look for this complete hemosiderin ring because one of the difficulties in patients with cancer, particularly in cancers that hemorrhage like melanoma, is distinguishing whether you're looking at metastatic lesions or cavernomas. And there are cases where it's going to be difficult if the patient has a known metastatic cancer. Just another example, could this be a developmental venous anomaly? And of course, the answer is no. You see on the post-contrast imaging, the draining vein, this potentially draining vein does not enhance. And you see all these flow voids here on the T2 weighted scan. So this again is an arteriovenous malformation, not a DVA. So in summary, you should be looking for these malformations because they are so very common. They can be mistaken for other diseases. And one of the problems that I think you probably got a sense of looking at these cases is they can vary considerably in their appearance. And so you'll see small DVAs, you'll see giant DVAs. And in some cases of developmental venous anomalies, you will see some T2 prolongation in the brain. This is not an indication that it's a different diagnosis. And so just accept that. I would say I've only seen it maybe 4 or 5 times in my career, but when you see it, don't get too excited about it. And use all of these techniques we mentioned to try to characterize these lesions. Any questions for me about that material?
No.
No, good.
No.
Good. All right, well, let's
Yes,
look at some.
can I have one? Sorry.
Yeah, of course.
If after all examination and see all sequences, we must have some doubt about is it really telangiectasia, capillary telangiectasia or not? When we can repeat examination, or it no need to do, how we can, I don't know, if we are doubt, we have after all examination, we have some suspicious maybe about is it metastasis of telangiectasia. I want to know when we can repeat maybe examination to see changes. 1 month, 2 weeks, 3 months.
Yes, I mean, I think that's and I have to tell you, there's no real, I'm not aware of any evidence-based recommendation on this. It tends to be a judgment call. But the way I think about it is that if you repeat the scan too soon, then you may mistakenly call it a telangiectasia rather than a metastatic lesion. So what would be too short? I would say I wouldn't repeat it in like 1 week, for example. Now, on the other side, if it's a metastatic lesion and you bring them back in 6 months, then you may be dealing with the consequences of enlargement of a metastatic lesion. So what is the right time between 1 week and 6 months? Personally, I use somewhere between, like, say, 4 to 6 weeks. Sort of depends on what my feeling is about the likelihood one way or another. So if I'm very suspicious it's a metastatic lesion, but I'm still not certain, I might bring them back in 4 weeks. If I'm not, I think it's a capillary telangiectasia, then I feel I might wait like 6 weeks or 8 weeks. But I would say I'm not. I think you have to sort of develop your own style that way. But I don't think you'd be going too wrong by saying 6 weeks. It's probably enough time for most tumors to change, and not so much time that we should worry about a tumor enlarging to the degree of patient may get symptomatic from, say, seizures or ventricular obstruction.
Thank you very much.
You're welcome. You're welcome. Okay, we're going to look at some cases, and I'm sure you're all aware, but the one way I think about dealing with clinical cases is that I know at the beginning that, as simple as it sounds, that common things are common, and that some diseases like meningiomas, as you know, can vary. They can be intraventricular, they can be intraparenchymal, they can usually are extraaxial, they can have restricted diffusion or not, they can calcify or not. So there's so many variations of meningiomas. There is a tendency for people to call everything that's extraaxial a meningioma. And yet we know there are some rare diseases that can look like meningiomas and are not. For example, in patients with myelogenous leukemia, CML, AML, they can have accumulations of tumor cells in the extraaxial space called chloromas that look just like meningiomas. So people will develop a style. Some people, the saying here is that if you hear hoofbeats, think horses, not zebras. But some people tend to think immediately of the exotic things, and other people tend to call everything some variation of normal disease. The best way to improve your diagnostic capabilities is to know what a lot of unusual diseases look like. And and if you think about our whole business of radiology, it's really just a game of recognizing things. And oftentimes we see things before we're even aware that we're looking at them, that we have some sort of way our brain processes the imaging, and we get a sort of a feeling that something's not right. So I'm going to just show you a number of cases, and I'm going to start with some cases that start with the history of vision change. So if you're looking at these cases, you want to look all along the visual pathways. And as you know, these go all the way from the orbit through the brain anterior temporal lobe with Meyer's loop, coming back to the occipital lobes. You need to examine the entire course of the optic pathways. But when the history is double vision, you need to be thinking in terms of dysfunction of the eye. And this can be due to masses within the orbit and also cranial nerve dysfunction. So if you're thinking of cranial nerve dysfunction, you have to then examine the cavernous sinus carefully and the brainstem. So your approach may be slightly different depending on how much history you have. But most of the cases I've seen where there's an error in interpretation in patients with visual problems is due to the fact that the clinicians are thinking too much about the eye and not enough about the brain. So this is a 16-year-old patient with headaches and bitemporal hemianopsia. And this is the sagittal T1 weighted scan. And Lucy, are you on? What would you think about I realize you would always have many more images than this, but how would you approach this particular case?
So I think it can be a craniopharyngioma or no.
All right, here's my question. Could this be a pituitary tumor?
Oh, this? Yes, right now.
Okay, so this is, I want to just make this point, is that if you're dealing with things that are in the cella and in the suprasellar space, you want to look to see if you can find the pituitary gland. Because all pituitary tumors, these giant adenomas, we see the macroadenomas, will be arising from within the pituitary gland, and you cannot find a normal pituitary in those cases. So if you can see a pituitary gland, and this looks like the pituitary in the inferior portion of the cella, then you need to move away from the concept it's of pituitary origin. Now, you mentioned craniopharyngioma, which I think is an excellent starting place for a patient of this age. Is there anything else we should consider in this location?
Meningioma in this location.
Okay, always a thought. They can arise from the tuberculum sella, they can arise from the diaphragm sella and the dorsum sella. Excellent. Okay, what else? Well, what lives in the suprasellar space? What travels back through that region? So the optic apparatus, right? So we want to think about, could this be a optic glioma, right? So, or hypothalamic lesion.
Oh, yeah.
So what would help you to establish the diagnosis of craniopharyngioma here? I'll give you a hint. Here's the CT scan. So what diagnosis would you offer now?
Also classifications and
Does that support the diagnosis of craniopharyngioma?
yes, why not?
Yes, very good. No, so your first inclination was exactly right. This is a craniopharyngioma. Typical appearance, young patient, suprasellar mass with these calcifications, very commonly seen with craniopharyngiomas. And so that is the diagnosis. These are mostly calcified in children, but remember, they're mostly not calcified in adults. So even though it goes by the same name, they're histologically different in children and adults, and they look differently in children and adults. One thing that can help you is you frequently see small areas of T1 shortening within the tumor on the T1 weighted imaging, and all craniopharyngiomas will have some degree of enhancement. So if it's not enhancing, it's not a craniopharyngioma. Here's an 85-year-old with headaches. And you see these calcifications in the orbits. Anna, is this a normal finding or not? And if it is normal, what would you call it?
Oh, the classification in orbit. I haven't seen it actually, really.
Oh, I'm sorry, you've not seen this.
I didn't see it in my practice, really. Examining a lot of adults.
Yeah. Well, so that's why I want to show, I just want to show this just so, you know, that we all see this together. This is not all that common, but it's common enough. And you'll notice that we see the same thing on the other side. So, so this can be mistaken for scleral banding, but remember scleral banding is more in the posterior portion of the globe. And this is calcification of the ciliary body. It's often called senescent calcifications. This is a normal finding with aging. So you wouldn't expect to see this in a 40-year-old, but it's very typical in patients who are 70 years and older. So if you see this,
do you believe I really haven't noticed it ever?
Yeah, it's well, you know,
patients, yes.
And you know what is possible is that some things that we see here you may not see there, and I think some of it is due to different. There's probably genetics and environmental reasons.
Yeah, maybe.
But
Maybe.
I have noticed in my career working at different hospitals and different locations that I see like whole families of diseases at one hospital that I don't see somewhere else. So I just want you to recognize this as a normal age-related change, just like we see calcifications in the, you know, in the ventricles, in the choroid plexus, and so on. So when you see orbital calcifications, this is a case of senescent calcifications. There's another phenomenon, they're called optic nerve drusen, that you can see right at the optic nerve head where it comes into the posterior portion of the globe. And then, of course, it should at least cross your mind, are you looking at scleral banding in patients with retinal detachment? This is a case of in this patient, you see it's in a different location and you see the globe is a little distorted. This is scleral banding. So these bands are placed around the globe, and the idea is that it treats patients who have retinal detachment. And the bands are never removed, to my knowledge. So you'll see these, you know, continually on imaging.
I'm so sorry. After retinal detachment, so it's after hemorrhage, or after after hematoma, or it's other genesis of this calcification.
Yes, it's you know, when in retinal detachment, there's hemorrhage under the sensory band there, and so the idea is to try to get it to reattach. And so sclerobanding is one of the treatments they use for detachment. And you're right, it is usually from hemorrhage.
Thank you.
All right, who's gonna look at this one? Hovhannes, what do you think about this patient who comes in with headaches? And so here we see the T1 weighted scan, the T2 weighted scan, and the flare scan. The eyes look a little funny.
To be honest, I'm not an expert, just like Anna said, of the ophthalmic imaging, but of course there is, yeah, definite asymmetric, you know, the eyes are asymmetrical. The right one is much smaller than the left one. Maybe there is some kind of implant there.
That's a good, okay, and that's a good thought. It just, you get the feeling that the eyes are distorted, right? it looks like it's squashed a little bit. And you'll see this dark band and a little bit of high signal there. I don't know if you can appreciate that, but that's what I see. And again, here it almost looks like a retinal detachment, but it's in the wrong side of the globe. So anyone, can you think of some reason why the eyes might look like this?
Maybe these are artifacts from lens.
From, what would it be from, do you think?
From optic lenses.
Interesting. Yeah, I mean, that would be a thought, but I can tell you now, this is, I mean, I'm a little surprised that this is not a common thing in Armenia, but it's very common here. Maybe your patients are more better prepared for MR imaging, but this is from eye makeup. So,
makeup. Yes.
eye makeup. Yeah. So women, usually women who put on a lot of eye makeup may get this artifact over the globes from the pigment and I guess it's the eyeliners and so on. So this is not abnormal. Now, but you can see it's problematic. So in terms of preparing patients for imaging, I try to get these people involved in scheduling the patient or preparing the patient, especially if we're doing an orbit examination, to have them take their eye makeup off, because this can be, distorts the globe to the degree that I think you lose some of your sensitivity to disease. But don't mistake this for pathology. Again, it's the fact that it kind of has an artifact look to it, as you mentioned. It doesn't seem real, but it does look odd. And but this is just from eye makeup. Now, there are some other things that you can see in the orbit. There's another thing that we see in the US. They're called eyeliner tattoos, so like a tattoo anywhere. But I think it's I guess it's more common in areas by the beach where women get tired of their eye makeup running and in the water, so they actually get a tattoo. And the other one are these magnetic eyelashes, which are I don't know. Do you see those in Armenia at all?
Yes,
Sometimes.
time to time. Yes.
Really? Yes. So they can be a problem as well. In fact, we did actually a paper about that, about magnetic eyelashes. And oddly enough, of all the papers that I've written, this is the one I've gotten most popular press interest. People would call me about this, and I think people love the idea of them flying off in the scanner. But you want to, again, in preparing patients, you want to make sure they take their eye makeup off, and if they have magnetic lashes, definitely take those off. All right. Marina, what about this case? This is a patient with some vision changes.
Muscles are abnormal, yes. Oh, sorry, Marina.
I don't like the muscle.
Okay.
I don't like the muscle. I think the orbital muscle is thicker than usual.
Okay.
It's by my opinion. In this case, I will do MRI with stir images to be sure that all is okay here. I don't know.
And what about the fact that you notice this muscle looks different than this muscle? In fact, if you look at the medial and lateral rectus muscles, they look different.
Yes,
Does
they
that,
look different.
And what disease do you think this patient might have?
Maybe parathyroidic thyroid problem, maybe.
Exactly. Okay, so this is that's exactly right. This is a typical appearance of thyroid eye disease.
Yeah.
And so the asymmetry of the muscles, the symmetry of the involvement is typical with thyroid eye disease. And these patients may have some visual changes.
Yes.
Particularly when the muscles get extremely large, they can actually compress the optic nerves. And the patients may have proptosis, the globe may look like it's protruding. So this is a typical case of thyroid eye disease.
Correct.
Now here's the same patient a year later. It also shows you one other feature I want to demonstrate for you, is the fact that in thyroid eye disease, the belly of the muscle is enlarged, but the insertion at the sclera is narrow. Kind of like, if you think about a leg, like the calf and the ankle, And so in patients with pseudotumor, orbital pseudotumor, the thickening will extend all the way up into the sclera. So this is when you see, especially in patients who have asymmetric disease, if you're considering pseudotumor, you want to look at the insertion of the muscle on the sclera, on the globe. The other thing you're going to notice is that the orbits themselves look unusual. Have you ever seen that? What is that from?
It's something like hernia.
It looks like it's herniating into the maxillary sinus. So I just wanted to show you that.
Thinning of the and thinning of the bone of the wall.
Yes, but this is actually a surgical procedure they do for thyroid eye disease. This is at orbital decompression. So the muscles were large enough that the patient was having some visual acuity changes, and they do this to create more space in the orbit to prevent the optic nerve compression.
Yeah.
So this
is oral surgeons call it blowout.
I'm sorry, I didn't hear. What did they call that?
Blowout.
Yeah, that would be a traumatic. Yeah, exactly.
Yeah. Exactly.
Okay, so this is thyroid eye disease with orbital decompression. So as you saw in this case, bilateral and symmetric. Usually there's relative sparing of the lateral rectus. Now, I mean, it can be enlarged, but it won't look as large usually as the medial rectus. The enlargement of the muscle does not extend to the sclera. And some patients with thyroid eye disease, interestingly, will have proptosis, but without enlargement of the muscles. And this is from increased fat in the orbit. So in patients who are referred to you for exophthalmos, then you want to be considering thyroid eye disease, even if the muscles are not enlarged, but the volume of the fat appears to be increased. Here's a 48-year-old with double vision. Susanna, you want to look at this case?
Yes.
So this is an adult with double vision. So where should we be looking on this scan, do you think? I mean, we should always look everywhere, right? But
Temporal lobe, occipital lobe, I think.
From brain scan.
I'll just go up through the orbits and all again. Anything?
Oh, not yet.
No, I don't see any.
Okay, so this is the reason,
right?
And this was read as normal. The clinician who read the scan didn't have the complete history, and this was read as normal. Now I'm showing you
And
a
what
single.
about cavernous sinuses to the right part? Is it okay?
Exactly.
Sorry.
Exactly.
I'm not.
It looks different on this
Yes.
side than
Oh.
this side.
Yeah, and it is
But this was
large
not
and it's not
appreciated.
normal. Yeah.
So again, just to emphasize that in terms of, as you all know, as radiologists, there are two types of errors. There are errors of detection and errors of interpretation. So errors of detection are detection is very difficult to teach. I mean, I can talk to you about differential diagnosis and how to interpret the finding and what to look for, but the detection part of our business is very difficult to teach. And so in an environment where currently many radiologists are being asked to read more and more cases, it's easy to miss findings like this. And this, as I say, this wasn't appreciated. But what helps you is if you have the history, you know where to look, right? So if I tell you to look, in a patient with double vision, I'm worried about the cranial nerves, then of course you're going to look a little harder in the cavernous sinus. So this was, I'm going to show you the next. Patient came back. Of course, they weren't happy with that being, not finding anything. And so the patient came back for an MR scan after a while. So here are the findings on this. Susanna, what do you think? What do you think's going on here?
On the right side?
Yes. What do you think that is?
Isn't it the venous sinus?
Okay, that is a reasonable thought. Could be an enlarged sinus, but we know the patient is symptomatic. So we're
Okay.
probably thinking there's something pathologic here. And then I want you to look carefully at the MRA. And you'll notice that this carotid artery looks different than this carotid artery.
Yes.
Mhm.
You'll also notice that the carotid artery here looks actually small compared to the other side. Does that help you in terms of diagnosis?
Meningioma.
Yeah, very good.
Fistula
So
or something.
that is this is, let's look at it carefully. So you notice that the mass is of low signal intensity,
Mhm.
right? So we know most neoplasms, aggressive neoplasms,
love that.
metastatic, they usually have a long T2 relaxation time. So this is dark on the T2 weighted scan. So when you see that low
Or
signal,
maybe inflammation of cavernous sinus.
that's an excellent thought as well. That
Talos
is
Sahank.
Tolosa Hunt, and that's always in the differential. That's always in the differential and oftentimes difficult to distinguish. Now, I will tell you, in most cases of Tolosa Hunt, you do not get carotid narrowing, but every once in a while you do. So I think that's a reasonable thought. But I think the imaging here, especially since we know this has been present for months, the stability of it would favor a neoplasm rather than Tolosa Hunt, which is a transitory phenomenon. And remember, there's the clinical history will help you because Tolosa Hunt is classically associated with a kind of a stabbing pain. So, and often it extends into the orbit a little bit. But I think I'm glad you brought that up. And I think, so it's in the differential of the low signal intensity cavernous sinus mass. Any other thoughts? Any other neoplasms that will look dark in the cavernous sinus? There's one other tumor that it often is low signal intensity on T2. You see it in the brain. When you see it in the brain, it's typically dark.
Neoplasms.
It's lymphoma.
Gliomas, maybe lymphomas.
Lymphoma. So usually when you see a low signal intensity in the cavernous sinus, you want to think about meningioma, lymphoma, sarcoid, and Tolosa Hunt is uncommon, but certainly it's in that differential. The encasement of the carotid, the small carotid artery, favors the diagnosis of meningioma, which is what this is, has been followed. This is what this represents. So again, just kind of a nice case of showing you, also showing you this phenomenon in terms of CT and MR, is that we're often challenged on MR to reach the correct interpretation of the findings, whereas on CT, the challenge is usually just finding the abnormalities. So CT, in my opinion, is much harder to read than MR in terms of actual detection of the abnormality.
A very interesting case. I'm so sorry. We had a doctor, radiologist Grosnikov from Georgia Neurosurgical University, and he was always saying, anytime you don't know what tumor is this, consider lymphoma.
Yes, yes, I think that's
Yeah.
that's a good bit of advice because it's so variable and it's relatively common here. And I think unfortunately is not, people may not think of it right off. So as I said, I mentioned we want to think about meningioma, lymphoma, and sarcoid. Do you see sarcoid there at all?
No, in my practice, never. We have lymphoma and a lot of meningioma.
Yeah, sarcoid, we do see sarcoid here occasionally. And it's one that is troublesome because, as you know, it's difficult to diagnose without tissue. Meningiomas, the narrowing of the carotid strongly favors meningioma. And particularly when you're dealing with masses that come into the sella, sometimes the differential is between a macroadenoma and a meningioma. And remember that meningiomas can narrow the carotid, but macroadenomas will never narrow the carotid artery. You have to be a little careful because, as I talked about in that talk some time ago about the patients with small carotid arteries, sometimes people mistake the small carotid for being related to the tumor when it's really due to variations of anatomy, like a hypoplastic A1 segment. So again, you need to look at the whole picture, but again, narrowing of the carotid favors meningioma. These are usually slow growing, and then they can present with headaches or cranial nerve dysfunction. All right, who wants to look at this one? Edward, do you want to look at this case?
Yes.
So here we have, this is an MR scan, and we see this is post-contrast T1, post-contrast T1. This is the T2 weighted scan in this patient. So what you'll notice that we have a lot of enhancement here and not much signal abnormality on the T2 weighted scan. And we also have, I'm going to give you, once you've looked at that, this is the SWI scan. This is susceptibility weighted scan. And again, it's a nice depiction of a calcification in the choroid plexus. This is the normal thalamus-striate vein, internal cerebral veins. And then we have this other business going on here. So what would you consider in this case?
It can be AVM, arterial venous malformation.
Anything else? And remember we talked earlier about sometimes that it's difficult to distinguish AVMs from what other benign vascular condition?
Developmental.
DVA.
Yeah. So I wanted to show you this case. These are what I call these telephone diagnoses, that you do better in some cases if you write down the findings than if you actually look at the images. And the reason I say that is if I were to, let's say I'm on call, I'm a resident in the hospital, I'm on call, I call my attending up and I say, I have this unusual case here. It looks like there are a lot of blood vessels. They all enhance after administration of contrast. I don't see any flow voids, and there's no abnormal signal in the brain. And I see a bunch of little vessels as well. And the attending might say, well, that sounds a lot like a developmental venous anomaly, right? I mean, it sounds like a DVA. But when you look at the imaging, this thing is so large and so unusual that it's hard to feel comfortable with that diagnosis, even though it ticks all of the characteristics that are typical for a DVA. So in this particular case, I want you to look at the susceptibility weighted imaging. And maybe not on this image, but if you look generally on SWI imaging, on some of the techniques that are used, oftentimes the arteries are bright and the veins are dark. So sometimes you can use SWI imaging to help you to determine if you're dealing with arterial flow or venous flow. And in a case like this, an MRA might have been helpful. But to illustrate how difficult the diagnosis was in this case actually did go to angiography. And so nobody really could believe this was just a DVA. So here we are in the arterial phase. We don't see any early appearance of a vein. And then in the venous phase, you see this gigantic developmental venous anomaly. The veins all appeared on time. And here it is, see the drainage here into the transverse sinus here and a little bit on the other side. So again, I'm showing you this case because this is the difficulty with these benign vascular malformations is they can look very strange. but they still in the end prove to be a benign condition. So this is, to me, like sort of the extreme of the appearance of a developmental venous anomaly, but is one that you should be able to recognize. And I think there's no harm done in doing an angiogram in a case like this, just because it is so unusual. But I think at the same time, it's important that we entertain the correct diagnosis as we go into it. So here you see the, you see the caput medusa here draining into this particular large vein, but there are many other vascular channels. So kind of odd appearance of a DVA. Here's an 18-year-old with vision changes, no calcifications on CT, and no history of or laboratory evidence of diabetes insipidus. Armin, you want to look at this one? So we're back in the suprasellar space here. So this is T1 weighted. This is flare. This is post-contrast T1. And I don't have the matching T1 axial, but you notice that there was no high signal intensity on the pre-contrast T1. So the first question I'll ask you, again, as I did in the previous case, and you should ask yourself this in masses in the suprasellar space, could this be of pituitary origin? What do you think?
Yeah, I think it can be macroadenoma, maybe.
Okay, but again, remember, what do you think this is right here?
This is hypophyse.
No, I think that's the pituitary gland.
Yeah,
So
pituitary gland, yes.
if you see the pituitary gland, you should probably move macroadenoma kind of not just down to the bottom of the list, but maybe off the list. So again, this is something that I've seen over the years, is that people will oftentimes move to the diagnosis of macroadenoma because they're so very common. And move away from other diagnoses, and the surgeons will go in, and I can tell you they're not happy when we call them a macroadenoma and they operate and they do a transsphenoidal approach, and then the first thing they see is the normal pituitary gland. So we need to be very thoughtful in approaching every case of a sellar and suprasellar mass. Ask yourself, do I see the pituitary gland? And if you do, move away from macroadenoma. So probably not a macroadenoma. What else should we consider in our differential?
Meningioma.
Meningioma, I think that's a good thought, although the enhancement's a little bit inhomogeneous and a little bright on the flare scan, but still it's a good location for meningiomas. Anything else?
Optic nerve pathology.
Optic nerve, excellent. So optic nerve disease, and you want to know if the patient has neurofibromatosis, because we know that optic gliomas are more common in patients with neurofibromatosis. But of course, you can also see optic gliomas in patients who do not have NF1. What about a hypothalamic hamartoma? Could this be a hamartoma?
Without calcifications.
Hamartomas usually don't calcify, but what is it about this that makes that extremely unlikely?
Hematoma should have a history of hematoma. I mean, post-traumatic hematoma or what?
No,
there is a disease called hypothalamic hamartoma. It's kind of an overgrowth of tissue, and but the enhancement makes that really unlikely. So it is not a hamartoma. So the things again.
And what about fat? I'm sorry.
Maybe craniopharyngioma.
I think craniopharyngioma
maybe
should be
hamartoma, not hematoma, or hamartoma.
Yes, hamartoma, but
hamartoma it enhanced, like on T1 I can see enhancement, maybe not whole, but it partially enhanced. It hyperintense on T1. I don't know, maybe hamartoma.
But typically they're really just normal. They're essentially they're called hamartomas because they're kind of disorganized, but still histologically normal tissue. So in this case, this proved to be a pilocytic astrocytoma. A CT scan was done. This was not enhancing. There was no calcifications. And so this went to surgery, and this proved to be a pilocytic astrocytoma. So optic nerve tumors are relatively uncommon, but you know from the normal pituitary gland that we're not dealing with a macroadenoma. The absence of calcifications in a young patient makes craniopharyngioma less likely, and oftentimes you have to go to surgery to make the diagnosis. So again, when you see suprasellar masses in a young patient, think about craniopharyngiomas. They're usually calcified, not all, usually calcified though. Optic gliomas, more common in patients with NF1. In patients with germinomas and Langerhans cell histiocytosis, the patients almost always have diabetes insipidus. So that's a bit of history that you should have before you read the scan. You want to know if the patient has DI. And then this disorder, which is relatively uncommon, but you should be aware of it, is the hypothalamic hamartoma. I'm going to show you this case just to sort of emphasize that here it's a little bit hard to see, but there's a mass here in the suprasellar cistern. Here you see the A1 segments. This is the pentagonal cistern over the sella. Here you see the mass better on the MR scan with some distortion of the midbrain. This is what it looks like on the T2 weighted scan. You see it looks just like the brain. And this is a particularly large case. This is a hypothalamic hamartoma. And these patients virtually always have seizures. And it may be from the involvement of the mammillary bodies. In animals, they know that lesions of the mammillary bodies can frequently result in seizures. And the seizures are usually this characteristic called gelastic or laughing seizures. These are very difficult to manage surgically because of the vital structures within the hypothalamus. And usually as a result of the surgery, the patients often have requirement of hormone replacement from interruption of the stalk. And they may have actually disorders that we're not commonly seeing, like eating disorders because from the disruption of the hypothalamus. There is one surgical approach that's sometimes used rather than approach it from the bottom, is to approach it from the top through a transcallosal approach that has been used. And there are specialized centers that actually treat these unfortunate patients with hypothalamic hamartoma. But again, these tumors do not calcify. They look just like brain. They, in my experience, they never enhance. So this is hypothalamic hamartoma. Now this is an oddity. I just want to talk you through this. This one looks like a hypothalamic hamartoma. It looks like brain on the T1 weighted scan. It looks like brain on the T2 weighted scan. It doesn't enhance after administration of contrast. But this is a good example of where history is everything. And this patient actually had a pilocytic astrocytoma that was treated with radiation. And this is the result of the treated optic glioma. So again, there is this overlap in imaging, but history should allow you to make that distinction. This patient had neurofibromatosis type 1. And in those cases, oftentimes the tumor does not enhance. Now, here's a patient with headaches and vision change. You see a few flecks of calcification here. Again, the patient's 50 years old. And this is what it looks like on the MR scan. Very high signal intensity on the T1 weighted scan with no contrast, very dark on the T2 weighted study. So as you look at this case, I want you to be careful about it because the temptation is to leap to the diagnosis of craniopharyngioma. And the problem here is to get too caught up in any one part of it. If you get caught up in the calcifications, you're going to favor craniopharyngioma, but we know that in adults, the craniopharyngiomas frequently don't enhance or don't have calcification. You'll also notice the T1 shortening is fairly diffuse, and it's very unusual that it's completely dark on the T2 weighted scan. Anybody want to offer a diagnosis here?
Lymphoma?
Aneurysm? maybe.
So I think aneurysm is a good thought, and I think we did a CTA because that was one of the concerns, that this was an aneurysm and the CTA was normal.
Oh,
Maybe melanoma.
Melanoma is a very good thought, often bright on the T1 weighted scan from hemorrhage and can be dark on the T2 weighted scan. There's no history of melanoma here. And but I think the other thing what I like about your diagnosis is you see the cella is normal in size. And that's very typical with metastatic disease to the pituitary gland, that the tumor grows out of the cella without enlarging it because it's growing so rapidly. So very good thought. Any other considerations? Well, let me throw this idea out. What about a Rathke's cleft cyst?
Yes, by a more characteristic, it can be.
Exactly.
Yeah.
So this is a case. In a case like this, this is a case we saw. We actually saw 2 of these cases over the course of a month or 2. Calcified supracellular masses with T1 shortening and low signal in the T2 weighted scan. This went to surgery. This was a Rathke's cleft cyst, a giant Rathke's cleft cyst. So again, this is the difficulty we have with imaging, is that this is a relatively common disorder presenting in a very unusual way. So again, be aware of that diagnosis, Rathke's cleft cyst. In fact, one way to think about Rathke's cleft cyst in terms of the imaging is what I do is I think about colloid cysts. You know that colloid cysts in the third ventricle frequently have T1 shortening and are black on the T2 weighted scan. And so Rathke's cleft cysts are sort of in that same family, in my opinion, that they behave in various ways. Sometimes they're bright on the T2 scan, but they're often dark on the T2 weighted imaging. The calcification is almost always not inside the mass, but at the periphery of the mass. And this is thought to be dystrophic calcification. But again, this is a giant Rathke's cleft cyst. Be aware that there is actually histologically a continuum between craniopharyngioma and Rathke's cleft cyst. And sometimes the reports come back a little ambiguous. So it's no wonder that we have trouble making the diagnosis if the pathologists are having trouble making the diagnosis. Now, this is a case we saw years ago. I'm just going to talk your way through it. Here's the CT scan. And on this patient comes in to the emergency room, worst headache of life. On the CT scan, you can see that there's blood in the, looks like blood in the supracellular cistern, and there's blood tracking out here into the sylvian. Yes, looks like an aneurysm, right? So we did a CTA, the CTA was negative. So now we're a little bit stuck. See the blood here filling the sylvian fissure, right? So subarachnoid hemorrhage, here's the MR scan. Supracellular mass, here's the T2 weighted scan. So let's analyze this. Could this be of pituitary origin? Because we know there's an entity of pituitary apoplexy, which will present with headache and can occasionally have subarachnoid blood. Could this be pituitary apoplexy?
No.
No. Why?
Because pituitary gland is normal.
Exactly.
We see the gland.
Excellent. Excellent observation. Right. So the pituitary gland, we see the pituitary gland. It's like a bowling ball sitting on top of the pituitary. Pituitary apoplexy is due to hemorrhage into a pituitary tumor. So if the pituitary is normal, this can't be pituitary apoplexy. So now we have this area of short T1 relaxation time. Now you'll notice on the T2 weighted scan, it's inhomogeneous. And it looks like there's something here that's different than this. And does that help you make the diagnosis here?
Rathke's cyst.
Rathke's cyst. Excellent. So can Rathke's cyst hemorrhage?
No, it can be just small part which we can often find with like small nodule in it, hypointense nodule. It, if I don't mention it, not typical to be like calcification. It can be small, but not.
Yeah, very good. So I want you all to see this case because what I find is that, there's a saying we have here is that I'll see it when I believe it. And, again, it's the saying usually is I'll believe it when I see it, right? But what that means is that if you know something is possible, you're more willing to look at things in a different way. So if you know that Rathke's cysts can hemorrhage into the subarachnoid space, then it's easier to make the diagnosis here. But the critical finding here is, of course, this nodule. And this was reported. This is a report from Journal of Neurosurgery, actually going back to 2005, talking about these Rathke cyst intracystic nodules. So you only see them, here's another one. You only see them when the cysts have a high signal intensity on the T2 weighted scan. And these are seen as areas of low signal intensity. And at surgery, these are like I think of them like pencil erasers. They're like little gummy nodules that live within the fluid in the Rathke's cleft cyst. Now, when the Rathke's cyst is completely dark on the T2 weighted scan, like that first case I showed you, then you're not going to see the intracystic nodule. But in cases where the fluid is a little bright on the T2 weighted scan, you may see the nodule. And when you see that nodule, you can be pretty sure there's a Rathke's cyst. And I know this is a Rathke's cleft cyst because this case actually went to surgery and they biopsied and resected that lesion, and it was a Rathke's cyst at histology. So be aware of this entity. It's called Rathke's cyst apoplexy. And I think it will help you because in patients with Rathke's cyst apoplexy, they don't necessarily have to go to surgery. And I think in that case, it helped us avoid the usual pathway for patients with subarachnoid blood, CTA negative will usually go to angiography and sometimes a repeat angiogram, which would be totally unnecessary in this case. Okay, here's a patient with acute unilateral vision change. And Remo, do you want to look at this case?
I don't like left optic nerve.
Good, good. And so we see this is the T1 weighted scan. And so is it normal for the optic nerve to enhance?
No, it's abnormal.
No, abnormal, right? It's normal for the rectus muscles to enhance, but usually the optic nerve does not enhance. Here's the diffusion scan. It's a little bright. Here's the T2 weighted scan. Here on this side, you see the optic nerve with fluid around it. Here, the nerve looks a little swollen, right, on the left side. So what do you usually offer for a differential here? And does age change your differential? For example, if I told you this was a 30-year-old woman, what do you think is a reasonable diagnosis?
Can it be like inflammation of optic nerve?
Inflammation.
Yeah, exactly.
Demyelinization if it's right. Yeah.
Right. So we call that optic neuritis, right?
Optic neuritis.
Which can be associated with multiple sclerosis. Not every patient with optic neuritis has multiple sclerosis, but frequently they will go on to have MS. But that is an entity. What if this was a 65-year-old patient with diabetes?
Diabetic neuropathy.
Exactly. This could be an infarct, right? Occasionally you'll see optic nerve infarcts. So again, that's usually the history usually helps us to establish the diagnosis and age. So again, this is good, but I just wanted to show you what the abnormal findings are in cases where the patient presents with monocular blindness. So if we have patients with, as you know, like a homonymous hemianopsia, which is usually in the occipital lobes, then there are patients who have bitemporal hemianopsia. Those are usually the suprasellar masses impinging on the optic chiasm. but when they have a single eye blindness, you can be pretty sure the lesion is going to be pre-chiasmatic, that is between the optic chiasm and the posterior globe. So look carefully at the optic nerves in those cases. And of course, you do need some specialized sequences to look at the optic nerves, namely fat suppressed post-contrast imaging, and you need to have fat suppressed FLAIR, T2, some sort of technique like that. All right. Anybody want to look at this case? Progressive vision loss in a 60-year-old. Left eye.
Left optic
Is
nerve.
it thrombosis?
So well, let's start. What's the finding?
Some hyperdensity around the
Left optic nerve.
yes,
Exactly.
hyperdensity should be the hemorrhage.
Okay, so hemorrhage or what else? Sometimes hard to tell the difference between on CT. Calcium, right? So it could be
Calcification,
calcium.
yes.
It could be blood. Yeah. So we're pretty sure. I didn't give you all the imaging, but we're pretty sure this is actually calcium. And you see the way it conforms to the margin of the optic nerve at the periphery. So what do you think is a reasonable diagnosis in this patient with vision loss, slow vision loss? So hemorrhage, of course, hemorrhage helps you a little bit in the sense that the symptoms should be acute, where this patient's symptoms actually go on for months.
So what was the question? What was the reason of calcification?
Well, yes, exactly. What do you think the disease process is here?
Maybe diabetes or.
So diabetes, we know, gives us vascular.
Should be
frequently,
symmetric, probably, in diabetes.
yes. Well, I can tell you when you have an optic nerve tumor.
Optic.
So you're usually dealing with either an optic glioma or a meningioma. And roughly speaking, if it's an older patient, it's usually a meningioma. And if it's a young patient, it's usually an optic glioma. So in this patient, this is a typical appearance of an optic nerve meningioma. And it gives you this encasement of the optic nerve. You see it extends back through the optic canal and may extend even up to the chiasm. But on the axial imaging, the expression they use here is called tram tracking or railroad tracking. So when you section this in the axial plane, you'll see the parallel calcifications along the optic nerve. So this is a meningioma. And you can see why these are difficult to treat, of course, in that location. So this is an optic meningioma. This one you should all be able to get, again, suprasellar mass, calcifications, a lot of enhancement, right? So this is a 15-year-old, this is a craniopharyngioma, all craniopharyngiomas enhance. This one I'm just going to talk you through. This is the first scan. The history is diabetes insipidus in a 5-year-old. Patient had this imaging, which shows a normal infundibulum. So again, if the patient has central diabetes insipidus, you want to be looking carefully in the hypothalamus and stalk. Here's the optic chiasm. There's the stalk, normal, normal, normal enhancement. So the one point I want to make about this case is that in a child with diabetes insipidus, even if the scan is normal, you should bring the patient back in a couple of months to re-image them, because frequently the symptom of diabetes insipidus will precede the appearance of the abnormality, the structural abnormality. So the presence of DI in a child is very concerning and should raise the possibility of either a germinoma or Langerhans cell histiocytosis. This is where we get into some of the unusual diseases but I want to show you this case. This patient came back, unfortunately, was not followed, came back 2 years later. This is the sagittal T1 weighted scan. And this is the axial CT scan. So anybody want to offer diagnosis here?
So the middle cranial fossa destruction.
You're right. There's destruction of the bone, and there's a hypothalamic mass in this patient.
Maybe
So-
germinoma.
So again, so that's why I'm showing you this case. When you see bone destruction in the setting of a hypothalamic mass, this is the typical appearance of Langerhans cell histiocytosis.
Histiocytoma.
So germinomas will not give you this bone involvement. Langerhans cell typically gives you bone involvement.
Ah, yeah. Thank
So
you.
this is a typical appearance of Langerhans. This is very, not that common disease, but again, you know, the reason we're being sort of paid as radiologists is not to make the common diagnoses, but the uncommon diagnoses. So this is Langerhans cell. All right, I want to talk about some vascular disease now, because that was really the whole point of this course. And so we'll go through some of these cases, some common, some uncommon. Do you want to
I'm
take a
very
break?
sorry. Can I give a question?
Yeah.
How often you measure the thickness of the stalk? For example, for Langerhans histiocytosis or for some other pathologies.
To be honest with you, I don't measure it. If you're, I mean,
Oh, yeah.
honestly, I tend not to measure it. I mean, it's really, for me, is more like it kind of looks big or it doesn't.
Okay, thank you.
And sometimes when it looks large, when you get into the history and the laboratory values, the you know, there's no functional abnormality. So I guess I don't rely on the measurements of the stalk. I mean, we sort of, you know,
Thank you.
I'm exaggerating, but the saying used to be that if you see a radiologist with a ruler, you're seeing someone in trouble. So it is, I think it's just a judgment call.
Oh, okay, thank you.
So let's look at this first case. This is a patient, 51-year-old, has this kind of an episode of confusion, comes in as like a stroke alert, has this CT scan and has this MR scan. So what should we be thinking about in this case?
Post-traumatic cystic lesions, something like that, or
Exactly, right. Callosal lesions are common after trauma, but there's no history of trauma here.
Stroke?
Okay, that's a good thought. And we know strokes can have restrict. How often have you seen strokes in the corpus callosum?
Never so often.
It's unusual. It's very unusual. Now, why is it unusual? Well, it's unusual because we have two anterior cerebral arteries, both potentially with supply to the corpus callosum. And the emboli tend not to go into those branches that supply the callosum. So it is very unusual to see callosal lesions. What is a more common lesion in the corpus callosum?
Cyst or ependymoma, some
Tumors, and what else?
Some contusion lesion.
Right, but usually we have a history of trauma.
MS?
Yeah.
Multiple
MS.
sclerosis.
Could be some demyelinization.
Well, I'm sorry, say again.
Some demyelinization.
I'm sorry, I didn't understand that.
Multiple sclerosis, maybe.
Yeah, multiple sclerosis, exactly, yeah. So when you see restricted diffusion, this is actually in two locations. Here you see it this is in the genu of the corpus callosum. You want to start by thinking through this. Could this be lymphoma? Lymphoma, we know, often has restricted diffusion, commonly involves the corpus callosum. High-grade glial tumors also can have restricted diffusion. So we want to be thinking neoplasm. but we're not crazy about neoplasm, right? There's not really any mass effect. It's in two separate locations. I think a reasonable thought is acute demyelination, but you want to keep infarct in mind, because even though infarcts are uncommon, that they do occur, they're frequently mistaken for neoplasm. And in my own experience, I remember a case where they actually biopsied a callosal infarct because it was subacute and there was some mass effect. So you want to avoid that problem, but you want to consider infarct. Now, if you're thinking of an infarct, I can tell you that in almost every case I've seen of a callosal infarct, the patient has had severe intracranial vascular disease. So if you're considering an infarct, as you probably should in a case like this, you want to do some sort of vascular imaging, because usually when there's a vascular abnormality, it's not going to be subtle. So this patient had an MRA done with the MR scan. Anybody want to offer a diagnosis here?
Well, it's like vasculitis or something.
Yes. So here you see this irregularity of the basilar artery, the distal vertebral artery. It looks like there's some narrowing here in the proximal posterior cerebral artery, narrowing in the posterior cerebral artery here, narrowing here. Now, again, I would caution you, MRA is not a great study for vasculitis, but in a case like this where these vessels are cut off, this is narrow, you know, so many abnormalities that this proved to be CNS vasculitis. So again, if you're considering a callosal infarct, usually by doing either a CTA or an MRA, you can usually make the diagnosis, because in almost all the cases you're going to see, the vascular abnormalities are not going to be subtle. All right, here's another patient. Kind of vague history, mental status changes. I remember I had a case like this one time where the chief complaint was the patient was, their golf score was going up. They were having trouble playing golf. So it's kind of an odd history, but this is the imaging. And so we see on the, I mixed these up a little bit. This is post-contrast T1. This is diffusion trace. This is the ADC map. Anybody want to offer a diagnosis here?
Maybe glioblastoma,
Lymphoma, maybe.
GBM.
Okay, exactly. So I think, so in this case, this patient, we want to think that the enhancement is fairly homogeneous, which is not typical for demyelinating disease. As you know, demyelinating lesions, so-called tumefactive demyelination, usually has peripheral enhancement. This seems to be enhancing centrally. There is mass effect you can see on the atria of the lateral ventricle. It shows restricted diffusion, not really dark, but kind of dark. And so your differential here should be lymphoma and high-grade glioma, and probably favoring lymphoma. And in a sense that most of the time when you see a restricted callosal lesion like this, it's going to be more often lymphoma than high-grade glioma, but I don't feel 100% that it's going to be lymphoma. And usually in these cases, I recommend that the surgeons biopsy it, because they usually they shouldn't really resect a lymphoma in this location. So usually with a biopsy, they can establish the diagnosis and institute therapy. So this is CNS lymphoma, honestly, a fairly typical appearance. All right, here's a 55-year-old with a cerebellar bleed. You see it's sort of, there's a little bit of edema around it. It looks like it's in the parenchyma, okay? Here is there were actually 2 lesions visible on the MR scan. Here's lesion 1, okay? See it here in the circle, here, here. And here's lesion 2. Okay, so
Is this venous angioma?
the first lesion,
Oh,
What do you think this is? Anna, go ahead. What do you think
Deviation.
this is, Anna? Anna, what do you think?
Some type of vasculitis.
Well, here we see a number of branching vessels that all enhance after administration of contrast with some.
Deviation.
I'm sorry.
DVA, yes.
DVA.
DVA. This is probably a telangiectasia and a DVA, definitely a DVA, right? We have enhancing branching vessels with a single draining vein that goes to the margin of the ventricle. So even though it's a little odd looking, this is typically from just a description of the findings, a typical appearance of a developmental anomaly. Now let's look at this second lesion. Now remember, this is the same patient that had the cerebellar hemorrhage. Now let's look at this lesion. So this is lesion number 1 was a DVA. Now look at this lesion. Again, branching vessels, single draining vein, but what's unusual about this scan?
Mostly look like AVM lost the signal of
There's a lot of small vascular channels with you get the feeling that these are little high velocity vasculature. And we have the cerebellar hemorrhage, right?
Yeah, AVM.
So this is actually
AVM, dural fistula.
This proved to be a dural fistula. This is a dural fistula, but again, both pathways will lead you to the same place, is that when you see, so one of these is a benign vascular lesion, one of these is a lesion that can hemorrhage, and that is either an arteriovenous malformation or a dural fistula, and obviously the angiogram is the definitive way to make the diagnosis here. So again, I think it's a nice example for you how you can analyze these lesions and sort of, you're not going to be right 100% of the time, but in that small percentage of patients where you're uncertain and you go to angiography, well, at least you're not going to angiography like in every case, right? You just go to angiography in the cases where you have really a question. Now this is the prize case. See if any of you can make the diagnosis here. Here's a 70-year-old comes in and he says, oh, I was told years and years ago I have a brain tumor. So here's his MR scan, and you can see there's a scalloped lesion here in the clivus. Here it is here. This is post-contrast. This enhancement here is just normal sort of enhancement you see along the dura. Here's the lesion on the post-contrast imaging. Okay. This is what it looks like on the CT scan. So what's your diagnosis here? Anybody?
It can be metastatic lesion.
Okay, there are two arguments against a metastatic lesion. Number one, the bony change is sclerotic at its margin, which tells you that this lesion is not destroying bone, it's remodeling bone, okay? The second reason is it didn't enhance. So all metastatic lesions enhance, basically. So it's a reasonable thought, but not the correct diagnosis here. What else should we consider? And I'm going to tell you, this is a typical appearance of a rare disease. You may never have seen it, but I want you to see it today.
Chordoma maybe.
Okay, so, and now we're in the right family. So you want to consider the diagnosis of a chordoma, because chordomas occur in this location, in the midline, in the clivus. They frequently destroy bone, though, not remodel it, and they frequently enhance, although not always.
No,
so,
thank you.
So on that continuum, so you're in the right category, but I want to show this to you. This is a disease which I can hardly pronounce the name. It's called ecchordosis physelophora, but basically I have to always look that up to spell it, but these are benign notochord remnants. They do not grow over time. They don't need surgery. And so you will see these on occasion if you're looking for them, but anytime you see a mass in the prepontine cistern and there are bony changes in the clivus, the two questions you should ask yourself are, number one, is the bone destroyed or is it remodeled? And number two, does the lesion enhance? If there's bony destruction and there's enhancement, then you're going to call it a chordoma. If it looks like this with remodeling and no enhancement, you should favor eccridosis. I think the best thing to do when you see these lesions is to follow them up in like 6 months to see if there's any change. But I want you to recognize this is a rare entity, but it can be mistaken for a chordoma, which of course would lead to a pretty impressive degree of intervention to establish the diagnosis here, which is not necessary.
I heard about this pathology at first. Thank you very much.
So this is, this is actually a paper and talks about, this is actually talks about patients who actually developed some fluid, a CSF leak from their eccridosis. But again, it's a lot of things. I don't know if you notice this in your own practice. It seems like once you learn about something, you start to see them. So again, comes back to this idea, the more we know, the more we see. And so I want you to recognize this variation of normal, sort of normal. Now, this is the flip side of that coin, right? So here's a middle-aged patient, unfortunate patient, came in with just headaches. I remember this was a physician's wife. And she came in and she had this lesion, large lesion, displacing the brain stem. Here it is destroying, you see it's destroyed the clivus, growing into the sphenoid sinus. See, it grew right through here. And if we look on the MR scan, it has this fluidy look to it. See that? There's enhancement, but it's not homogeneous. It's a little bit of dot of enhancement here and there. Anybody want to offer a diagnosis here?
To be honest, I was thinking some kind of parasitic infection.
No, I mean, and I think that's a good thought. We think about cysts with a variety of infections. Now, and I think that is a good example of how our location influences how we think about disease. Because in my practice, I see virtually no parasitic disease. But I know in Armenia, you may see some variations of infectious disease that we don't see here. But
yeah,
the
because I'm sorry, because for example, when we differentiate the two types of so hydatid disease, so it can be regular hydatid disease or the alveolar type. So when there are multiple cysts that are invading the other structures around, so since there are like multiple tiny on the post-contrast examination, there are like small lesions that are all grouped together and invading the structures around.
I have never seen a case of that in the brain. I wonder, can you send me those cases, or if you have a few cases, you might want to think about writing those up, because there's really not much in the literature, at least that I'm aware of, on that. But I'd be delighted if you could send me a couple of those cases to look at.
To be honest, most are in the liver from my practice, and I think that everyone else will agree. But of course, if there will be anything regarding the brain and the adjacent structures, of course, I mean, with pleasure.
Yeah, no, I'd love to see them. Well, anyway, this is at least without, if we set infectious disease aside, which I think is always important to think about, but this is a typical appearance of a chordoma. So it has two features that establish the diagnosis. Again, much like the other case, it's in the mid sort of clivus, but there's true bony destruction in this case, not remodeling. And the characteristic feature of a chordoma is this kind of watery look to it. The chordomas have this profound T2 prolongation in them, and they usually don't enhance solidly. Now, these are malignant tumors in the sense they will grow and destroy tissue, but they tend not to metastasize. They're locally invasive. They are, terrible disease to treat, and patients suffer. They have severe headaches associated with these and disability. But this is a typical appearance of a chordoma.